Welcome to The Explainer. I'm so thrilled you're here today because we're jumping straight into the fascinating world of pancreatic sonography. If looking at medical imaging ever feels like you're just staring at TV static, you're absolutely in the right place. Our whole goal today is to translate those complex grayscale ultrasound images and really explain this with best and simple visuals that you can instantly grasp. So, let's just dive right in and decode exactly what we're looking at when we scan the pancreas.
Here's our game plan for today. We'll start by meeting the pancreas, then establish the normal ultrasound view. From there, we'll compare acute versus chronic pancreatitis, identify tumors, masses, and cysts, and wrap it all up with our key evaluation takeaways.
Section 1. Meet the pancreas, location and structure.
Okay, so let's start with a really crucial term, retroperitoneal. The pancreas actually sits way back behind the main abdominal cavity, tucked right behind the stomach. Knowing it lives deep in this anatomical space really helps us understand why ultrasound is such a fantastic, non-invasive first-line tool to peek past the surface and evaluate it.
Structurally, we can break the whole organ down into three really simple parts: the head, the body, and the tail. I want you to go ahead and build a mental map of this layout in your head right now. Visualizing these three distinct sections is going to be incredibly helpful later on, because as you'll see, certain diseases and masses absolutely love to hide in very specific regions of this map.
Section 2. The normal ultrasound view, establishing the baseline.
Let's tackle a big piece of medical jargon right out of the gate: echogenicity. This is simply the ability of tissue to bounce ultrasound waves back to the machine. So what does our healthy baseline actually look like? Well, a normal healthy pancreas should look homogeneous, meaning it has a nice even texture, and it should show medium-level echogenicity. Actually, a great pro tip here is that a healthy pancreas will almost always appear just a little bit brighter than the liver sitting right next door.
Another huge part of establishing our baseline is looking for smooth and well-defined margins. When you're looking at a healthy pancreas, the borders of the organ need to be crisp. There shouldn't be any blurry edges, and the surrounding area has to be totally free of any focal masses or pools of fluid. We just want to see clean, smooth lines.
Now here's an absolutely crucial number for you to remember: 2 to 3 millimeters. Running right through the middle of the pancreas is the pancreatic duct. And in a normal, healthy patient, this duct really must measure less than 2 to 3 millimeters across. I know, it's a super tiny, precise metric, but it is literally vital for setting our baseline.
Section 3. Acute versus chronic pancreatitis. Spotting the difference.
Okay, let's look at acute pancreatitis first. All that inflammation and edema, basically swelling, makes the whole organ enlarged and hypoechoic, meaning it looks noticeably dark. The margins get really irregular, and you might even see some fluid pooling around it. Now contrast that entirely with chronic pancreatitis. Here, the gland does the exact opposite. It actually shrinks, becoming atrophic. And it becomes a lot more echogenic, so brighter, because of all the dense fibrosis and scarring. You're also going to commonly spot these hard little calcifications and a dilated or widened pancreatic duct. So the takeaway: dark and swollen versus shrunken and bright.
Section 4. Tumors, masses, and cysts. Identifying lesions. When we're scanning for pancreatic tumors, we're usually hunting for irregular, hypoechoic, which again means dark, masses. And hey, remember that mental map we built a few minutes ago? Well, this is exactly where it pays off. These tumors have this incredibly strong tendency to develop specifically in the head of the pancreas. That is essentially your prime suspect area.
Which brings us to a really fascinating clinical clue: the double duct sign. So why does this happen? Well, think about the plumbing. If a tumor forms right there in the head of the pancreas, it can physically pinch off and block both the pancreatic duct and the nearby bile duct. When both of those ducts get backed up and dilate, it creates this super distinct visual sign on the ultrasound. It's a classic flashing red flag.
But, not all masses are tumors. Let's make sure we delineate between a few cystic lesions. First up, we've got pseudocyst. These are well-defined, fluid-filled collections that usually pop up right after a bad attack of pancreatitis. Basically, they're just leftover pockets of fluid. Then we have other cysts, which are quite a bit more complex. These might contain internal septations, which are kind of like little walls built inside the cyst, or even solid components.
Section 5. Key evaluation takeaways, the master checklist.
Let's quickly walk through this master summary matrix together. For literally every evaluation, you've got to check these specific features. First, size and texture. Normal is homogeneous,
Abnormal could be enlarged from acute edema or maybe atrophic from chronic fibrosis. Second, echogenicity. Normal is slightly brighter than the liver. Abnormal could be a dark hypoechoic tumor or a super bright fibrotic gland. Third, margins. Normal is smooth. Abnormal is irregular, maybe with surrounding fluid. And finally, the duct. Normal is less than 2 to 3 millimeters. Abnormal is dilated, maybe even showing us that classic double duct sign.
Now, we do have to acknowledge a bit of physical reality here. Because the pancreas sits all the way behind the stomach, bowel gas can sometimes physically block the ultrasound waves, which kind of limits our visualization. It's just an inherent physical limitation of the tech. But honestly, despite that, ultrasound absolutely remains an excellent, lightning-fast, and accessible initial imaging tool for pancreatic assessment. It is without a doubt always the best starting point.
Before we wrap up, I want to leave you with a quick challenge. If you scan a patient and see a dilated duct, but a shrunken fibrotic gland, are you looking at an acute crisis or a chronic condition? Think back to our baseline to deviation framework. A shrunken fibrotic gland with a widened duct points right away to chronic pancreatitis, not an acute swollen crisis. By really striving to explain this with best and simple visuals, alongside structured checklists, decoding complex medical imaging becomes completely manageable. Thank you so much for joining me in this explainer today. Keep visualizing, keep questioning, and I'll catch you next time.